Welcome to Pulse&Pressors, where critical care gets crystal clear. Malignant hyperthermia is a life-threatening hypermetabolic crisis triggered by anesthetic exposure. Rapid recognition is essential, as the metabolic rate increases uncontrollably due to unregulated calcium release. The condition escalates quickly and demands immediate intervention. MH is driven by dysfunction of the RYR1 receptor, causing explosive, sustained calcium release from the sarcoplasmic reticulum. This triggers continuous contraction, massive ATP consumption, heat production, and metabolic collapse. Without intervention, acidosis, hyperkalemia, and cardiac arrest occur. MH is inherited in an autosomal dominant pattern, most commonly involving mutations in RYR1. CA-CNA1S mutations occur less frequently. Penetrance varies, meaning not every carrier will express MH. Following any confirmed case, all first-degree relatives require screening. The strongest MH triggers are succinylcholine and volatile anesthetics. These agents directly activate unstable RYR1 receptors and initiate the hypermetabolic cascade. Exposure to both a volatile agent and succinylcholine increases the likelihood of MH significantly. Safe agents include nitrous oxide, propofol, ketamine, etomidate, benzodiazepines, and non-depolarizing paralytics. These medications do not act on the RYR1 receptor and can be safely used in MH-susceptible patients. The earliest signs include rapid and disproportionate rises in end-tidal CO2, tachycardia, and generalized or masseter muscle rigidity. Temperature elevation often follows but is not required for diagnosis. Hypercarbia remains the most reliable early marker. Late signs include severe hyperthermia, metabolic and respiratory acidosis, hyperkalemia, arrhythmias, and dark urine from myoglobinuria. These findings indicate significant muscle breakdown and increased risk of renal injury and cardiac arrest. Diagnostic clues include profound end-tidal CO2 elevation, masseter rigidity, elevated potassium, rising CK levels, and pigmenturia. No single finding is definitive, but the constellation provides rapid diagnostic clarity. The differential diagnosis includes sepsis, thyroid storm, neuroleptic malignant syndrome, heat stroke, inadequate anesthesia, CO2 absorber malfunction, ventilator circuit obstruction, and pheochromocytoma crisis. These conditions may mimic MH physiology, but require different treatments. Initial management begins with stopping all triggering agents, delivering 100% oxygen, hyperventilating the patient, and calling for the MH cart. Succinylcholine must be discontinued immediately. Early intervention decreases mortality dramatically. Dantrolene administration is the cornerstone of MH therapy. The initial dose is 2.5 milligrams per kilogram intravenously. Two formulations exist: Dantrium or Rivanto, 20 milligrams per vial requiring 60 milliliters sterile water, and Ryanodex, 250 milligrams per vial requiring only 5 milliliters sterile water. The reduced volume and rapid reconstitution of Ryanodex allow for faster dosing in critical situations. Dantrolene acts by inhibiting the RYR1 receptor and halting calcium release. This stops the hypermetabolic cycle, reduces CO2 production, and improves rigidity. Maintenance dosing must be continued for 24 to 48 hours to prevent recurrence. Supportive management includes active cooling, cardiovascular stabilization, fluid resuscitation, treatment of hyperkalemia, arrhythmia control, and monitoring with Foley catheter placement to track urine output and detect myoglobinuria. ICU complications include rhabdomyolysis, acute kidney injury, disseminated intravascular coagulation, pulmonary edema, and persistent metabolic derangements. Intensive monitoring is required to manage these complications effectively. Myoglobinuria management includes aggressive hydration, urine alkalinization with bicarbonate, maintenance of high urine output, avoidance of nephrotoxins, and serial CK and renal function monitoring. Persistent hypercapnia, airway edema, or generalized muscle injury may require reintubation or prolonged ventilation. Even after dantrolene, CO2 production may remain high initially. Recurrence can occur within 24 to 48 hours, necessitating continued dantrolene dosing and strict trigger avoidance. ICU monitoring is essential during this period. Following the acute crisis, patients undergo genetic testing and caffeine halothane contracture testing when indicated. Proper documentation and family counseling are essential for future anesthetic planning. Prevention requires trigger-free anesthesia using total intravenous anesthesia, avoiding succinylcholine and volatile agents, and ensuring immediate access to dantrolene. MH-safe protocols must be rehearsed regularly. High-risk patients include those with known mutations, positive family history, previous MH reactions, or unexplained perioperative hyperkalemia. Young muscular patients may have more dramatic presentations. MH is a rapidly evolving metabolic emergency requiring immediate dantrolene and aggressive supportive care. Early recognition, recurrence prevention, and post-crisis genetic evaluation are essential to optimal outcomes. This is Pulse and Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.